Informative talk. Now I would like to invite Dr. Soumya Narayanan. She has completed her DNB in ophthalmology and fellowship in orbit and oculoplasty from Agarwal Eye Hospital and Research Institute, Chennai. And currently she is working as a visiting oculoplastic surgeon at various hospitals in Calicut. She'll be talking on when thyroid is the culprit.
Good morning, all. So, when a patient comes to your clinic with these features like lid retraction with lateral flare, lid lag, proptosis, periorbital fullness and fat prolapse, conjunctival congestion, exposure keratitis, extraocular muscle restriction, and compressive optic neuropathy, you will be thinking firstly of thyroid. So, thyroid eye disease is an autoimmune disorder affecting the orbit mainly in the third to fifth decade with a female preponderance, and it is mostly associated with hyperthyroidism, and it can also occur in patients with hypothyroidism and euthyroidism. So the pathogenesis, the main culprit is the fibroblast, where there is insulin growth factor receptor and TSH receptor. The corresponding antibodies are being attached to the receptor, and the orbital fibroblast will proliferate and form fibromyoblast. It will produce more of fat and glycosaminoglycans, and there is a inflammatory cascade by the T lymphocyte. So all these things will lead to the above mentioned symptoms and signs. So for evaluation, we need a complete ocular evaluation including diplopia charting and visual fields. Thyroid function test should be done along with a thyroid peroxidase enzyme and thyroglobulin antibody, and rule out any other autoimmune disorders. Imaging in the form of B-scan, CT bar, MRI orbit or USG neck is also important. So in the imaging, you can see there is fat hypertrophy, muscle enlargement, radiological activity in the form of inflammatory edema, and also we should look for apical crowding, especially like Barrett's index or effacement of the perineural fat by the muscle. So Rundle's curve is actually gives us the natural course of the disease, where it has an active phase and a quiescent phase. In the active phase actually lasts for 1 to 1.5 years, and in that time, if you can intervene effectively, we can reduce the impact of the disease. And later, when it is in the quiescent phase, we can do reconstructive surgeries if needed. So thyroid eye disease, the two important questions is whether the patient is in the active phase or in the quiescent phase, and also in what type of severity the patient is having. So for clinical activity score will help us in seeing whether the patient is in active phase or not. So in the first visit, we have to look for any pain or pressure over the periorbital area, pain with eye movement, swelling of the eyelids and conjunctiva, redness of the eyelids and conjunctiva, inflammation of the caruncle and plica. So if the score is more than 3 out of 7, it is considered to be active. And the follow-up visit, along with the 7 measurements, we also look for any increase in the proptosis, decrease in the eye movements, and also decrease in vision. So out of 10, if the patient is having a score of 4, we have to consider it as an active disease. So severity is classified by the UGOGO, where it is mild when there is a mild proptosis and lid retraction, and moderate to severe and sight-threatening in case of dysthyroid optic neuropathy and severe exposure keratitis. So this is a protocol by Dr. Santosh Honawar, published in IJO. So in the active TED, we have to see if the patient is in mild severity, we can use conservative measurements like controlling the thyroid status, lubricant, oral steroids, ask the patient to quit smoking. At this stage, the patient is having severe lid retraction. This time itself, we can give a intra-LPS steroids to decrease the lid retraction. And in case of moderate to severe active thyroid eye disease, we can give a low-dose IVMP pulse therapy. If there is good response, we can wait. And if it is suboptimal, we can, along with the IVMP, we can also add low-dose radiation and immunomodulation. And if the patient is having severe sight-threatening disease, high-dose IVMP pulse therapy is given. If there is good response, we will continue with the immunomodulator therapy. And if it is suboptimal, we have to go for early decompression. When the patient becomes inactive, we can go for the sequential surgeries. So in the 2021 UGOGO meeting has said that we can even use mycophenol mofetil as the first-line treatment. It has equal effectiveness as the IVMP treatment. So methylprednisolone acts on the fibroblast, B cells and T cells to inhibit the pro-inflammatory substances. And immunomodulators like mycophenol mofetil, cyclosporin, azathioprine and methotrexate can also be used either as a adjuvant therapy, or in the case where the patient cannot take an IVMP, we can go for these treatments. So there are targeted therapies like the revolutionary intervention is that tripotunab, which is affecting the insulin growth factor receptor. So this is actually, the studies are showing it has same efficiency as the decompression. We can also use rituximab, which is targeted against the CD20. Others are tocilizumab, blocking the interleukin-6, infliximab, adalimumab, and etanercept. So orbital radiation can also be used as a adjuvant therapy when the IVMP management is not effective in patient. So it is given as 20 Gay in 10 divided doses over 2 weeks of time. So to conclude, if the patient is in inactive stage, we can also do surgical management if needed in the order of orbit, lid, EOM, and lid. Thank you.
Thank you very much, Dr. Soumya.